Good afternoon, everyone. Welcome to the first CAQH CORE Town Hall of the year. Thanks for joining us. So we have a jam-packed agenda for you all today. First, we will introduce the 2022 CAQH CORE priorities and goals. And then we have a spotlight where we're going to cover the new and updated draft rules up for review by CAQH CORE participants. And those rules include the draft updated infrastructure rules, the draft updated eligibility and benefits data content rule, and the draft new attachments operating rules. Following that, we will give you an update on the advanced explanation of benefits advisory group efforts, which are developing consensus-based recommendations to support the different components of the AOB requirements of the No Surprises Act. Then we'll jump into an update on our pilot and measurement initiatives, followed by a Q&A. So you can download the presentation slides now from the handout section of the GoToWebinar menu. You can also download the slides and recording on our website after the webinar. Additionally, a copy of the slides and the recording will be emailed to all attendees and registrants in the next 1 to 2 business days. Please feel free to forward the email to anyone in your organization who might be interested in these materials as well. Questions can be submitted at any time using the questions panel on the GoToWebinar dashboard. That can be any technical issues that you might be having, as well as questions that we will be addressing at the end of our session during the Q&A. So with that, I will turn it on over to CAQH CORE Director Bob Bowman.
Great, thank you, Daphne. And I do want to extend Daphne's welcome to you for our first webinar of the year, where we do want to cover some of the big topics that we have going on. Just as a quick recap, though, remember that CORE is an organization made up of its participants whose mission is to develop operating rules through our consensus-based approach. Again, we're looking at where the industry is at today, where it should go for tomorrow, and then concrete collaborative steps to reach that particular vision. We do develop sets of operating rules, and we have been designated by HHS to do exactly that. Again, we do develop those rules, though, in a consensus voluntary approach first before we go to HHS for any consideration. We work closely within the industry. We make sure that our participants are a broad multi-stakeholder group that includes both health plans, providers, clearinghouses, vendors, as well as various provider and health plan associations and SDOs. So again, we make sure that we have all of those different pillars within our industry represented, and making sure that we have their feedback and approaches to how we can best solve some of the biggest challenges related to administrative burden within the industry. We do want to highlight some of our priorities and goals for this coming year. So on the next couple of slides, you'll see that we really have worked hard to identify what those are and what they should be, and then how we can take and build out a pathway to achieving those. So on slide 6, you'll see that from our industry survey that we conducted later in 2021, as well as the polling questions that we asked during our webinars and feedback that we have, the advanced EOB, prior authorization, patient data sharing, and standard agnostic operating rules all received really high levels of support from our core participants, and focus on many of our topics and goals for 2022. But let's not forget some of the other items that we've also received that we'll be considering would include claim status, EFT, ERA, and other types of items. On this slide, you'll see that some of the prioritization also related to developing a roadmap to support the interoperability as technology continues to advance. So how can we, as a consensus-driven body, work with our technical components, our technical expertise, and experts within the industry to really find the best pathway forward? If anything, also The COVID pandemic has really impacted telehealth and delivery of medicine and care through that means. So it's still a big priority topic for many of our participating organizations and will be addressed by CAQH CORE in 2022. Another key component that folks like for us to work on is the certification, recertification, accreditation programs within the industry, of which core certification is really key and integral to the process for delivering the transactions and the data according to the core operating rules. We also have pilot testing and standardization. We'll have an update on that a little bit later too in our current progress, but it's really key to have that SLA information, ROI information, as we approach different ways of implementing that not only the transactions, but the change of data, the different types of connectivity, acknowledgements. How do we make sure that we do that in the best approach? And that is often through piloting and testing those implementations. Other topics that were also important were population health and compliance and reporting requirements. We've also asked which of the core features are the most significant for your organization. Really, why do you find CAQH CORE an important component of the industry landscape and as a voice for the industry? And many of you mentioned, as you can see here, the impact of the industry that we have, multi-stakeholder, making sure that we have all of those different silos as part of our commitment for consensus is also a key. The HHS designation, working directly with the federal government to ensure that we can make progress and change in the way that we conduct the transactions, how we exchange data. Certification is also a key component, as well as our education materials, our mission-driven, and also the board guidance that we have. Remember, our board is made up of both health plans and provider organizations working together in consort, imagine, and working to ensure that we can bring that consensus-driven approach to the industry. Now, how do we do that, right? On the next slide, right, we like to lead the industry through our approach to drafting operating rules. We bring everyone together. We make sure that we have that multi-stakeholder group. We collaborate to ensure that we're working towards those best approaches. We develop resources to help bridge the gaps that exist. We create and update operating rules that address market needs that are actually addressing some of those biggest concerns within the market for that particular time period. We also drive for adoption. We ensure that folks, right, the rubber has to meet the road. You say this is a problem, we work towards consensus to resolve those problems. We develop the tools for the implementation of those systems and applications to ensure that they can meet and really surmount those issues and problems. And then we have the certification program to prove that the industry is moving forward. All of that said, in slide 10, our 2022 goals include to use our integrated model, rule writing, certification, pilot measure, industry relations, right, to align industry across current and emerging standards and technologies. Number 2 is to continue to successfully serve as the national operating rule author to improve the efficiency, accuracy, and effectiveness of the industry-driven business transactions. We'll continue to look at what transactions those are, but for this year, we're looking at the AEOB transparency, healthcare claims, value-based payments, value enhancements, and maintenance. So really moving into that payment space and prospective payment space, right, with the AEOB. And finally, as always, to serve as the effective gold standard for industry certification for operating rules and the underlying business standards. We're going to continue to support new certifications for new entities moving into the market and or still those laggers that might not have certified just yet on all of the transactions, and also work through our recertification program that we kicked off last year. Remember, many entities will have to go through a recertification program to ensure that they're still continuing to meet the data needs, the infrastructure requirements, and the connectivity concerns that are all part of the operating rules. With that, I'm going to hand the call back over to Daphne to moderate our first polling question.
Thanks, Bob. I'm going to go ahead and launch our poll. So we want to hear from, launch that again. There we go. So we want to hear from you about which of our various rule development and maintenance topics are the highest priority for your organization, And you can go ahead and select all that apply. We have standard agnostic operating rules, advanced EOB and price transparency, healthcare claims, BBP, patient data exchange. As Bob highlighted earlier, we really want to hear from you all, and CORE serves as this unique forum that responds to various industry needs and priorities. So thank you for completing our little poll here. All right, a couple more seconds and then I'll hand it back over to Bob. All right.
Great, thank you for participating in the poll. And what I would like to do now is really just kick off and highlight some of the rules that are under review currently by the CORE participating organizations as they prepare for their ballot. We drafted new rules as well as updated old rules to ensure that we're continuing to move the industry forward with, again, that technology component and the data content component. So we have developed 3 new sets of rules. The first one is new attachment operating rules. These help close the automation gaps and optimize the attachment process, again, both for prior authorization as well as claims. We've taken both of those use cases to heart. We've worked really diligently over the last course of almost 2 years now to ensure that we can help close that gap between attachments for both of those use cases. We've also ran an update to our eligibility and benefit data content rule. Again, one of the very first earliest rules that we ever developed way back in 2005, and we have now updated that with additional content requirements. We'll hear more about those specifics in just a minute, but we do want to make sure that, again, we're ensuring that providers have the coverage information that they need to have a complete interaction with the patient at the time of service. And lastly, we've also updated our infrastructure rule. This includes some of those really basic foundational requirements that lay the tracks for interoperability, how the data moves from point A to point B, and making sure that it's not lost, it doesn't fall in a black hole. The provider knows exactly where it's at all times and what to expect when they should receive a response back from the health plan. So those infrastructure requirements are really key as well. On the next slide, you'll see the quick timeline of, really not that quick, we've been working on for 2 years, between our attachments rules, our eligibility update, as well as our infrastructure rule update. We did a lot of work over the course of the 2 years with many, many calls with our CORE participants. We straw polled, had feedback forums, had many discussions through each one of these subgroups or task groups, as well as with the CORE board, to ensure that everyone's on board with the requirements as they were being developed, and to ensure we're working with industry consensus in mind, right? We don't want to move forward if it's not going to have a positive impact, and making sure that we are, again, that progressive step forward, not the low-hanging fruit, but really progressive in how we can move the industry forward. So on the next slide, before we get into the details, I just want to do a quick recap. All of the updated and newly drafted operating rules are out for final vote. So the CORE participants have that ballot in hand right now as they are perusing and reviewing those requirements. We have here in the green highlight there, you see the 86, 83, 87, and 83% support. Those were the percentages of support from the review work group. We go through this iterative approach, both at the task group, a review work group, and then the all CORE ballot. So all of these 4 rules had very, very high levels of support, with 83% being the lowest. And again, as you can imagine, the challenges that CAQH CORE has with our multi-stakeholder approach, sometimes it is like herding cats and ensuring that we're meeting those requirements. But the requirements that we've drafted to date have been very successful with those high levels of support. Now, to move into a little bit of the detail for each one of these rule sets, I'm going to hand the call over to Emily.
Great, thank you, Bob. As Bob mentioned, the new attachments rules, which we will dive into first, really establish key requirements specific to the prior authorization and claims use case workflows to close that automation gap and really optimize the attachments process. So to backtrack a bit, when we talk about attachments, we're referring to the exchange of medical information or supplemental documentation to support an administrative healthcare transaction, like a PA or a claim. So these draft rules that are being voted on right now really serve as the bridge between clinical and administrative data. And given the range of standards and specifications that exist and lack of federally mandated standard, the exchange of attachments, as I'm sure many of you are acutely aware, has historically been a really manual process. So Bob highlighted the robust process that CORE participants went through to develop these rules, including the multiple feedback forms, discussions, straw polls, and ballots. And that's really to ensure strong rules for the industry. And finally, to ensure that the draft rules support interoperability between clinical and administrative systems, the requirements do address attachments sent using both the X12275 transaction and additional documentation sent without using the X12275 transaction. So that could be via resources, HL7C CDAs, .pdfs, and the like. Next slide, please. So first, I'll review the specifics of the attachments rules for the prior authorization use case. And again, as I mentioned, the requirements applied to both attachments sent using the X12275 and those sent without using the X12275. Another thing to note before we dive in is that the attachments PA infrastructure rule aligns seamlessly with existing core prior auth 278 infrastructure data content rules, and really establishes requirements seen across the core infrastructure rules. So if you're familiar with the existing infrastructure rules, many of these requirements that I'm about to mention will sound really familiar. And the ones included in the attachments prior auth infrastructure rule include standard acknowledgement methods and response time, minimums for document size and amount of data that must be supported by both front-end and internal document management systems, standard methods and response times for returning errors, system availability uptimes, and a common format and flow for companion guides to ease the implementation of the attachments transaction. So keep these requirements in mind. I'll reference them again as we transition to the next slide. But first, we'll look at the details of the attachments prior authorization data content rule. So the focus of the data content rule is really to address one of the major pain points highlighted throughout the development process, and that was to connect an attachment with the original prior authorization request or claim submission. This is also known as reassociation. So the requirements included in the data content rules establish specific codes and reference data that will ease the reassociation process. Again, this addresses major pain point for both plans and providers that we heard throughout the process. And then the draft attachments claims rules really mirror the attachments rules for PA. So as I mentioned, for the infrastructure rule, the requirements include system availability, companion guides, acknowledgements, data error handling, processing modes. There are two unique requirements to the healthcare claims attachments infrastructure rule that I do want to highlight for you. The first is an additional file size requirement that applies when using the X12275 to send an attachment. And you'll remember that the file size requirement discussed on the last slide establishes minimum file sizes for the front-end servers and internal document management systems. And this additional file size requirement specifies that health plans must support the capability to receive multiple attachment LX loops for one healthcare claims submission. Again, this is unique to the healthcare claims infrastructure attachments rule. And the other requirement that's unique to that rule specifies that the health plan's attachment policies must be accessible electronically in a consistent location, such as a plan's webpage. So similarly, attachments claims data content rule requirements mirror the data content requirements established in the attachment PA data content rule. There's just one unique requirement in the rule specific to the reassociation of an attachment to a claim submission. And that's really just that an appropriate link code must be sent. And there are many benefits to adoption of these rules. As Bob mentioned, this is a multi-stakeholder consensus-driven process to really target key issues in the attachment workflow, specifically the unnecessary back and forth between providers and health plans, manual follow-up by providers to ensure attachments were received and linked with the original submission, and the inconsistent use of attachment standards. So some of the benefits, though there are many, that these rules really will address are that they address attachments sent using the X12275 transaction and additional documentation sent without. This is really critical to addressing interoperability between administrative and clinical data within the industry. They also establish key infrastructure requirements. As I mentioned, those align with existing core infrastructure rules. They require specific codes and reference data to simplify reassociation. Again, major pain point heard throughout the development process. And finally, they provide additional guidance to communicate data and processing errors to limit the follow-up from providers as to whether attachments were received and all the information necessary was included. And with that, I will hand it over to Taha Anjawala to discuss our next topic. Taha?
Thanks, Emily. For me, I'd like to spend the next few minutes talking about the core operating rules that are part of under review, which are currently CORE has published, but that our CORE participants have worked to update. So the first topic I'm going to talk about is our eligibility and benefit data content rule that's being considered as part of our the vote, and then the other topic is our core infrastructure rules. So starting off with the core eligibility and benefit data content rule, I'd like to just kind of talk about the rule itself and just to make sure everyone has a foundational understanding of what the existing operating rule requirements are before talking about the requirements that are being considered as part of the rule update. So first of all, the operating rule requires health plans to support requests for benefit information for at least 12 months in the past. Next, operating rule requirements require the return of certain data elements in response to various eligibility and benefit inquiries, including providing the name of a health plan, providing coverage, and certain patient financial information for a designated set of 51 service type codes. And this patient financial information could include things like co-insurance, co-payments, base and remaining deductible amounts, and also being able to differentiate amounts between in-network and out-of-network services. Further, the existing operating rules support patient identification by requiring the normalization of last names to aid with member searches and matches when trying to ascertain what benefits are. And when a member cannot be found or a health plan is not able to respond to a provider's eligibility inquiry, CORE has also published rule requirements that really define a standard way for reporting those errors to help providers pinpoint exactly where the problem may be. And the last existing requirement that I'd like to highlight applies to vendors. And this operating rule requires vendors to be able to detect and display all the different data elements that CORE has operating rules for to ensure providers have access to all the adequate eligibility and benefit information. So on the next slide, I'll talk about that. Now that we reviewed kind of the existing CORE rule, and that rule was the first rule actually published by CORE nearly 15 years ago. And this rule set has been updated over time. And as industry needs have evolved over the last several years, stakeholders are requiring more robust and enhanced information pertaining to eligibility, coverage, and benefit information. So as a result of this, in fall of 2020, CORE asked its membership to identify, what are the priority areas for operating rule development that CORE could do in 2021. And CORE participants identified improving the eligibility and benefits process as one of those top priority areas. So to work on updating the eligibility and benefit operating rule, CORE launched the Eligibility and Benefit Task Group in April of last year to evaluate the various opportunity areas that could apply to the update. And over the course of last year, the task group went through a consensus-based process where participants agreed to draft updated rule requirements across the following topic areas that you see on the slide. So the first area includes addressing industry needs to communicate benefit information related to telemedicine. The second area relates to the expansion of the number of service type codes that require explicit inquiries. So I mentioned on the last slide there were 51 in the current rule. Now with the rule update, that goes up to above 175 at service type codes supported by the rule. The third area includes requirements for communicating the number of visits or services left on a benefit. For example, it's really important for a provider to know, how many physical therapy visits maybe, or how many speech therapy sessions may be left. So we've added that requirement in as well. The fourth area includes requirements for health plans to respond to coverage and benefit information at the procedure code level. The fifth area requires the communication of a prior authorization if needed to obtain on a specific procedure or service type. And the last area, number 6, requires the delivery of eligibility and benefit information related to membership and tiered benefit plans. So as you can see, the task group worked hard over the course of last year to identify what the industry priorities are and draft rule requirements to support the enhanced need for additional eligibility and benefit information. So the process of updating the eligibility and data content rule was definitely intensive and detailed, and was facilitated by compromise and lots of consensus. So next, I'd like to move into our next topic, which is our core infrastructure rules. So starting off with some background on our infrastructure rules. So each set of operating rules published by CORE includes an infrastructure rule with the requirements for processing modes, whether it be batch or real time, response time, so how fast should that transaction be sent and acknowledged. So 20 seconds or less for real time, and batch response times could vary. System availability, so how often do systems need to be available to enable to receive an electronic transaction. Connectivity requirements, acknowledgement, so ensuring that every transaction sent has an acknowledgement back, and standard companion guides to ensure that implementation of the operating rules and the transactions are uniform across the industry. So those are some examples of our infrastructure rule requirements that we have for each set of our operating rules. So our core infrastructure rule update was initiated following feedback from industry stakeholders and the core board, to really adjust and align what our requirements were, at the time with updated technology and evolving business needs. So in the fall of last year, core participants were surveyed to gauge support for, what areas of the infrastructure rules should be updated, and they were gauged support for updating, system availability requirements and response time requirements across all rule sets. And the findings were then reviewed and further vetted by the core review work group in the fall of last year. So on the next slide, I'll talk about some of the operating rule updates that were considered. So through the survey and review by the review work group, there was clear consensus that emerged across all 8 infrastructure rules, such as connectivity, processing modes, companion guides, but the significant discussion occurred related to system availability needs. So system availability discussions included, provider recognition that, that healthcare is a 24/7 business and there was needs for systems to be updated and running. And also health plans had dialogue that systems today are much more complicated than they were 10 years ago, and system uptime is often dependent on, other IT infrastructure that may not be within an EDI department's control. So in efforts to reach consensus, review work group participants agreed to make substantive adjustments for all infrastructure rules by updating our weekly system availability times from the current 86% to 90% per calendar week, so increasing that uptime, but also recognizing the fact that, as those systems are complex, by adding in a new quarterly system availability so that health plans and their agents may use up to 24 additional hours of system downtime per calendar quarter to help support with system migrations and the more integrated system needs that may require downtime in excess of the weekly allowable system downtime. So on the next slide, I'd like to highlight, so in addition to the substantive updates to our system availability requirements that I mentioned on the last slide, from 86% to 90%, and the addition of a 24-hour quarterly downtime period, I wanted to make sure that you were all aware that there were also some non-substantive updates that were made to our core infrastructure rules to help with clarity. And these were related to our core connectivity requirements and companion guide requirements. So all core infrastructure rules were updated to reference the most recent version of core connectivity, which is version 4. And the reason for this is that, as the industry trends evolve over time, core connectivity version 4 will be required for all infrastructure rules. And this will be baked into our core certification process, and where entities will be required to implement the most recent version of core connectivity, as those organizations go through our recertification cycle to ensure that there's standard and uniform connectivity across the industry. Secondly, our companion guide references were also updated, and this was related to our currently companion guide references specific X12 versions of the transaction that point to version 5010 of the X12 implementation guides. So our non-substantive update here was to make our companion guides version agnostic so that companion guides could align with any additional versions of X12 transactions that the industry may use. And as Emily talked about, some of our attachments transactions point to the version 6020 transaction. And lastly, I wanted to highlight that processing mode response time requirements were not updated as consensus was not reached. And our requirement around processing, especially for real time, remains the same, and batch processing varies according to use case. So with that, those are our key updates for our eligibility benefit data content rule and infrastructure rule that is being considered by our core participants. And so we'll have more information to come later on. But now I'd like to pass the call over to Bob to talk about our efforts around advanced explanation of the benefits. Back over to you, Bob.
Great, thank you, Ty and Emily, for the overview. Lots of detail, we know, so again, don't forget to download the slide deck for future reference as you review. It really can provide a handy guide for what those specific requirements are and how they interrelate with each other. But we do want to provide a quick update on our Advanced Explanation Benefit Advisory Group. They have completed part of their work to date. And on the next slide, you'll see exactly what that is. We hosted that group throughout the summer and into the fall of 2021, and they published, as a result of their work, a guidance document, which is actually hyperlinked directly from the slide to it. But it does illustrate how the industry can meet the advanced EEOB requirements by leveraging uniform frameworks and industry standards. It was developed using our CAQH CORE consensus-based approach. There are specific recommendations related to connectivity protocols, messaging standards, and specific data content to help support that provider and payer exchanges for the good faith estimate. We also hosted an industry webinar in November, once that was published, to help advocate and evangelize the approaches that the core participants published in their guidance document. As I related earlier, this is going to be a continued topic for CAQH CORE. We'll be hosting other parts of this advisory group to peel back this onion and better understand some of the challenges that the industry faces related to this topic. So again, stay tuned. As a core participating organization, you should be hearing from us shortly about some of the work we plan to do throughout 2022 on this topic. With that, I'll hand the call over to Mariana to provide us a quick update also on our next topic, which is the prior authorization pilot and measurement study that we've been working on over the last year. Mariana?
Thanks, Bob. As Bob mentioned, I'll be speaking regarding the PA pilot initiative, which began with the goal to partner with industry organizations to measure the impact of existing and new CAQH CORE prior authorization operating rules and corresponding standards on organizations' efficiency metrics. CAQH CORE partnered with Cleveland Clinic and Prior Auth Now to observe the efficiencies that occurred from having the 278 standard implemented in real time with the CAQH CORE operating rules and API technology. CAQH CORE began observing the efficiencies made to Cleveland Clinic's prior authorization approval process after Prior Auth Now solution went live in Cleveland Clinic's database and management system in February 2020 through a two-phase study. Initially, PAN solution began with one national plan and then eventually incorporated 34 plans with multiple lines of business into their solution. In the first phase of the study, CORE worked with Cleveland Clinic to observe initial improvements by understanding the workflows of the technologies working together, on-site visits, and a provider staff satisfaction survey, as prior authorization volumes were still too low to do a quantified study at that time. CORE, Cleveland Clinic, and Prior Auth Now reported the results of the efficiencies observed and experienced on the first case study webinar in August of 2020. In phase 2 of the initiative, a deep dive on the case study, CORE, Cleveland Clinic, and Prior Auth Now identified and analyzed prior authorizations submitted through Prior Auth Now compared to those not submitted through Prior Auth Now. These were analyzed via a cross-section comparison for prior authorizations occurring between June of 2020 to February 2021 for the 5 efficiency metrics listed here. Details around the priority metrics were reported by time and volume on the webinar conducted in October 14th of 2021 and will also be shared in an issue brief that will be released early this year. In the following slides, I'll go into further details around the efficiencies observed. Moving to the next slide, we can see before there was an automated process, every step to conduct a prior authorization was done manually. From the staff creating a case after an appointment was scheduled to accessing a payer portal to submitting a prior authorization request and then having to wait to hear back if additional clinical information was needed. And if so, submitting the appropriate information, then manually following up for a final determination status and updating the Epic system with the appropriate status. Every step was done manually, and on average, this process would take 45 minutes to complete a single prior authorization. The prior auth solution was able to leverage API technology, the X12278 standard, and CAQH CORE operating rules to bring automation to Cleveland Clinic staff's prior authorization workflow. If we look at the example of an MRI being scheduled, the API technology auto-generates a case for a prior authorization request to be submitted after a patient has scheduled an appointment for an MRI. After the case is created with pre-filled information, a prior authorization request is auto-generated and submitted to the health plan in real time. In that same moment, a real-time response is returned from the provider indicating a need for a clinical survey. The clinical survey captures specific data related to the prior authorization request and is often customized for that specific type of prior authorization, as mentioned in this case, diagnostic imaging. The longest time to conduct this automated prior authorization request is the time it takes for Cleveland Clinic staff to begin work on the prior authorization after it enters their work queue. From their EHR, Cleveland Clinic staff is able to answer the corresponding request for additional information and submit the appropriate information without leaving their EHR. Within 4 minutes from submitting the additional information, Cleveland Clinic staff receives a response to final determination, which is automatically updated in their Epic system. So a process that used to take on average 45 minutes is reduced to 4 minutes. As we can see, technology standards and operating rules work together to automate this process at different steps of the workflow. The API technology is integrated into the EHR and pulls the correct information. The standards create a consistent set of data to send the request for a prior authorization, and the CAQH CORE operating rules provide the requirement sending the requested data in a timely manner. On this next slide, we can see through the study and the efficiency metrics observed, The use of technology standards and CAQH core operating rules were able to enable the real-time exchange of robust data to accelerate prior authorization adjudication and ultimately enable timelier delivery of patient care. From the time a patient appointment is scheduled to a prior authorization being adjudicated, the overall time frame was reduced by 6.7 days when using the automated process, allowing patient services to be scheduled and conducted more quickly. Over 25% of authorizations that were fully automated with no manual or staff interaction were approved. And authorizations that were approved upon initial submission, meaning the first pass, were adjudicated a week faster when submitted through the automated process compared to manual submission. A metric related to the CAQH core operating rules included authorizations that were pended for additional clinical information. These were adjudicated on average 4.3 days faster because of the automation. This was due to the fact that providers were submitting more accurate information to the health plan initially, and thus more specific information was requested by the health plan to adjudicate the request. Lastly, even the most cumbersome of the prior authorization processes, authorizations that require peer-to-peer review, were adjudicated 11 days faster when submitting through the automated process versus those that could not be, which is a substantial impact to the delivery of care for these often needed and extreme services or healthcare products. So through automation, we see diagnostic imaging and many of the subsequent services are expedited in their delivery. The time to evaluate and diagnose the patient are substantially reduced, allowing for more timely care. Now I'll pass it to Daphne for a Q&A.
Thanks, Mariana. Great job. So just a reminder to everyone to enter their questions into the questions panel on the lower right-hand corner of your screen. If we don't get to your question, you can also email us at any time at core@caqh.org. So I'll kick us off with some questions around core certification. So either Bob or Taha, can you walk us through the timeline for the certification test suite in the event that these new rules are passed by core participants in the core board?
I can address this one, Daphne. So once the rules are approved for core certification, test suites will be made available you're not talking, if you don't mind on mute, I'm getting some background noise. So back to the question. So core certification test suites will be made available immediately after all our rules are published, but certification won't be available until after we work with our core authorized testing vendor to get the rules updated as part of certification testing. So we do allow about a 2-year implementation window. So for those organizations that may be up for recertification, you would have that 2-year window to implement the rule updates prior to needing to recertify on those rule requirements. And depending on your situation and where you are on your recertification cycle, we can work with you on identifying those timelines on an individual basis.
Can you also clarify what exactly core recertification is?
So core recertification is in that core certified entities. So once an organization achieves core certification, they receive their initial certification. They have to recertify every 3 years in order to maintain their certification active.
Thanks, Taha. So we keep repeating the phrase consensus driven, and that's truly one of CORE's central values. I think it would be kind of useful to go back through the 3 different draft rules and new rules that we've highlighted, and maybe provide a little bit of additional color on the discussions around how we got to these rules reach their current iteration. So maybe we can start off with attachments and a quick highlight on how we got to where we did and what were some of the key discussions around the attachments rules.
This is Bob. I can start with that one. It's a great question because it really does highlight the unique place that CORE exists within the industry. We started working on attachments over 2 years ago when our CORE board members, both the provider-based organizations as well as the health plans, really began to want to work on this issue. There have been lots of talks, as there always is kind of within the industry, around the burden that in particular attachments have for the industry. This goes both from claim submission as well as prior authorization and many other use cases, audits, grievance and appeals that are kind of claim-based. So this type of situation, lots of resources are spent by both of those constituencies. And many of the vendors and clearinghouses that have products in this space all kind of do it a little bit differently. They look at, usually because there's not a HIPAA required standard for what is an attachment. So the industry has gone many different ways in trying to solve this particular issue. We still have, fax servers are used quite extensively at the provider's office, and they feed those types of transactions, those documents into fax server of the health plan, that then routes those to the claims adjusters or to the PA adjusters who are reviewing this documentation. So how do we resolve that using that 1980s, 1990s technology for this type of interaction that really could be simplified with better technology, better standards, using standards, as well as associated operating rules to, again, that glide path, having those foundational requirements for infrastructure. So we surveyed, we did a complete environmental scan that included surveying, site visits, interviews with key players that already have systems in place or applications or products in place, as well as those providers and health plans that really have some, really want to make changes to how they did it back then, 3 years ago. So we launched our own advisory group, again, that really consisted of a lot of the major players in the industry, as well as some of the technologists, some of the people that are really at the forefront of what's going on when it comes to the technology and transactions and who's doing what. So that really a huge effort. Most of our effort was really front loaded in that process. The surveying, the interviewing, hours and hours and weeks of time before we even launched our first work group, which we did start with PA because we had just finished our draft of PA rules. So everything was kind of really fresh in people's memory from those discussions. So we launched PA, and then we followed with our claims attachments work group immediately. So again, keeping everything fresh in mind. And also many of the learnings that we have, right? The same kind of systems or applications might be used, some of the same technologies, some of the same attachment standards that are being used in the market, from PDF to the 275 to the CCD transactions from HL7. All of those are in our milieu, right? They're all part of our environment today. So how can we, as an organization that's building on consensus, address issues when it's really kind of really fractured? People are at different levels of maturity. They're kind of all over the place. Again, looking at those things that really can drive to consensus are some really foundational things, right? If you're going to use the 275, as Emily mentioned, then it's best to use it this way. And these are the best data elements, particularly for reassociation. If you're not going to use the 275, but perhaps you're going to use some other connectivity, some other enveloping, you're going to use the CCDA over FHIR or not over FHIR, whatever that technology is or whatever that transaction is, here's the best way to do it. Here's the way to ensure that providers, plans, the system vendors that are out there building these applications and tools for providers and health plans to more successfully communicate with each other. Here's the foundational components that will help them do that. And so that's really where the work from our work groups came from, for that consensus approach, looking at the infrastructure, looking at some of the key data content requirements, and really peeling back those first couple of layers of that onion to build that consensus.
So more specifically with the infrastructure rule update, what we were hearing from health plans is that a lot of them were already meeting the 86% system availability requirement. Can you provide a little bit more detail on how we reached the 90%?
Yeah, definitely. This is something that, as you can imagine, can be quite contentious because many of the systems and applications that are in place today, particularly for eligibility or claims or claim status, have been around for quite a while. And those are the, true blue workhorses of the industry. How many millions of eligibility transactions are ran every day? How many millions of claims are processed and submitted from a provider to health plan today in this country, right? It goes into the billions. And so how do we ensure that if we're going to move the needle on a couple of these really key infrastructure components that, again, we have to get consensus, but how do we do that? And as you can imagine, providers have really been pushing for ensuring that they have access to the data, right? We often hear, because it is true, that healthcare is a 24/7 business. There are always providers available. There's always systems running. So how do you make sure that that works from not only an application that's up for all the time, that clearinghouses are able and ready to receive and respond to transactions, as well as the health plans. And so it really was part of our effort this year, this past summer, to work with those stakeholders to drive to that consensus. And so we moved from that 86 to 90%, along with those additional timeframes for major systems. I think Emily did a great job in sharing that many systems are now, it's not just, you can't take down just one component. Usually the whole house of cards has to come down and be rebuilt overnight for those systems to really migrate all of the changes of coding that takes place from the front door to the back door and every floor in between. All of that has to usually go down, migrate that code, and turn the lights back on, right? Set it all back up again. Many systems are now like that. And some of the systems are not just as simple back-end databases that we're used to, right? Many things have moved to the cloud. The actual infrastructure for the technology has changed quite a bit over the last 20 years. Although from a provider's interface, they're still hitting the submit button, right? They don't see that. So how can we ensure that from the provider's perspective to the health plan's need are all being met? Again, that consensus-based approach, moving from 86 to 90, was fraught with lots of discussion and lots of debate. Some systems are so big that they couldn't guarantee that they can do that at 90% of the time in a given week or a given month. That's part of the reporting requirements that we have as well. So how do we do that best? We really worked with both the providers and the plans. We had it up as high as 99%, 97%, 95%, every percentage point in between 86 to 100. We debated that in those work groups. And there are some strong emotions and strong advocates for one percentage point or another. But the 90% is what we came down to for consensus. And that we know we can move forward with. And again, as we saw, some of those requirements had 83% level support. So we know that's the sweet spot, and those are going to, and that's what went out on the ballot for the award.
Thanks, Bob. That's really helpful. Question here around our value-based payment efforts for the upcoming year. Are there any subgroups or advisory groups in the making? What do the VBQ efforts look like for CORE this year?
Another great question. I think that what you would expect to see from CORE would be to continue our advisory group. So those members of our advisory group, and if you want to join in with that advisory group, please let us know. We can get you on that roster, but that roster will be probably being peppered with, again, making sure, what the next topic is going to be that they will cover. The timeframes for when we will cover that will probably be towards the end of the first quarter and into the second quarter. So give us about 30 days to wrap up some of the internal work that we're doing, our environmental scanning, before we launch that next advisory group work. So again, we will be working on the topic. We will be sending out to our advisory group some of the potential dates that we'll be launching that with. So it's a little internal work that we're doing here at CAQH before we launch that to the broader industry and advisory group.
Thanks, Bob. And I'll drop in the chat our VBP page, which we'll be updating. It has a interactive module that shows some of our past work and opportunity areas in the space, as well as some previous webinars in case folks want that information, and we'll be sure to update that in the next coming weeks as we develop our efforts there. So I'm gonna keep the Q&A open for another couple minutes or another minute in case folks have any last questions before closing up the call. So we do have a question about NCVHS and what NCVHS review will look like if we plan on presenting any of our updated or new rules for federal mandate in the coming year.
That's a great question again. And one thing that we always do is that once we have the results from the core ballot, we send those results to the core board, and the core board then reviews the results of the ballot, the comments that come in on the ballot, as well as they take their own, and they have their own internal discussions. They decide and consider to move what, if any, rules to NCVHS for consideration. And then the core board would basically pen a letter asking NCVHS to consider this set of rules or that set of rules or all of the rules. So again, the core board will make the decision of which ones will move forward to NCVHS for consideration. And again, it can be all of them, it could be none of them. It's up to the core board to make that decision. But either way, just as Tom mentioned, we will build out a voluntary core certification program for the rules. The rules will become published, and entities can start pursuing the system mitigation and migrations that would have to take place to meet those requirements and become core certified. So it's not a must that has to happen. It's something that the core board will make that decision on how we engage with NCVHS on this particular set of operating rules. If I were a betting man and I live in Louisville, Kentucky, so I probably am, I would say that many of these rules will probably go forward for NCVHS consideration because attachments is such a key component, and there's still so much industry abrasion with that particular transaction or interaction between the provider and the plan. So I can see that one moving forward.
Thanks, Bob. All right, I am going to go ahead and close up today's call. We have a lot of things coming up in 2022, and we'll be sure to have our different education webinars and everything posted. So more to come. Please stay tuned, and thank you so much for joining us today.